I've got a great treat for you this week. We're sharing some rare footage from my last Dr. Tim live conference where I carried out a full face treatment in front of a live audience. I cover treatment design, anatomy and complications, as well as injection techniques for cheeks, tear troughs and temples. And if you like what you see, it's perfect timing because on the 4th of December this year, 2021, I'm doing another live event. And if you want to be in this year's audience, it's an amazing opportunity to join me, to come and meet me personally, as well as Miranda and the team. And we'd love to see you there. So click on the link down below. So I'm going to now attempt to lay the first layer of support for her cheek. So I'm replacing that lateral fat pad. I'm going to put a cannula in and do a little bit just on top here, just a first pass. And I'll probably adjust that again later on. Pilot hole, I'm trying to aim it in the direction my cannula is going to go. And I only need to go through the dermis. I don't need to go through everything. And that's enough for me. I'm now in the hypodermis, in the fat. So getting your cannula in, I see all sorts of ways of getting it in, as in there's this kind of stirring thing with a needle where you put the needle in and then go round and round and round. My idea of what's going on there is the sharpest bit of the needle is doing something underneath, and then the blunt bit that's not really that good at stretching the skin is just going round and round. So it's not necessarily that effective. And mostly I don't think you need to do very much at all other than just aim properly. Just pop a little swab on top of that. So anyone who's seen me do this before, I think I'm unusually gentle compared with many. I really don't like the idea of tearing through to get somewhere. I like to try and find an easy route. So I'm just trying lots of different angles, maintaining my overall direction of aim and trying to sneak through without causing any trauma. And we're right back now. So now I'm right where I want to be. I'm on the superior surface of the zygoma. And this is where, particularly with a cannula, it's very sculptural. I'm just kind of, it's a lot like shaping if you're a sculptor and you're chipping away a bone, but it's the reverse because it's additive. But I'm just adding little bits. I'm seeing what the result is like. I'm checking it, doing a bit more, and just gradually increasing the volume. This is Voluma as well. So I'm also, having asked that question about the temple, I am actually slightly in the temple now because I can see a little shadow from where I'm at. I don't know if you can see it, where I can just see the connection between the cheek and the temple, and I just think I'm going to smooth that slightly. But going back to how I started, I have an aesthetic goal, which is I want this to project out a little, but not too much for the temple. And I'm continuously referencing that goal as I'm going. I use the what I can see in terms of visibility of the cannula to adjust, to decide where the product goes. As the cannula bulges, I think, yeah, that's what I want to achieve. So that's your lateral projection. Let me do a little bit of smoothing. So the next thing I'm going to do, which is harder for you to see, is do some anterior cheek projection. I just know from if you turn your head a little bit to the side, you might see that this area is projected more further forward than up here. So I'm basically trying to get the cheek to project a little bit more like that. And that's part of what will help lift the lower face as well. So with this, I prefer to do deep, and it's onto the anterior surface of the zygoma. You can feel the angle of the zygoma here. So what I'm now seeing in my mind's eye is this alignment with the zygoma, but I'm on the anterior surface. So looking at the skeleton, you might be able to picture that it's the anterior surface of the zygoma I'm trying to augment. Now the artery, as we've said, it runs medial to it, the facial artery, and then beneath it or inferior to it as the transverse facial arteries. This is a relatively safe place to go deep and touch the bone. Aspirate. And then a little bit of molding just to shape that in. Your supporting hand is very important for cannulas in terms of feeling where the product is going, adjusting the tissue as you're sliding in. Finding that easy route. I think painting off on the way I layer the product. I'm just trying to layer evenly and sculpt that shape. It's adhered. It's underneath the structures, but it's not. Most cannula procedures are in the hypodermis. You can be in deep hypodermis or superficial hypodermis, and it's actually why quite often I do quite like using needles to get a little bit deeper. But it's pretty hard with the cannula, even with your best interests, best attempt to go very deep. So where is it good to be deep? Particularly where you might have a little bit of puffiness occurring. So usually in the tear trough, we want to be a little bit deeper. And I'm going to do a little bit in the lateral lid cheek junction just to blend the cheek in with a couple of injections of Voleft. Now these I want to be on the periosteum. So much safer in terms of the puffiness that you might get. It's a better place to have them. So lateral lid cheek junction is a really important part of periorbital restoration. I still see people treating the tear trough as if it's a different entity, and you see the medial aspect of the tear trough improved, and then they leave the lateral aspect. That's it's down to a training gap, because the lateral lid cheek junction is usually more aging than the tear trough, in my opinion. So I'm just trying to get, there's a little line I can see. I don't know how well you can see it on the screen, but I just want to get that little line to project up. That little shadow there is really important for overall restoration. So once again, I'm aiming in such a way that if I go too deep, I'm not going to hit an eyeball. It's kind of crazy. One of the cases of blindness, temporary blindness, thankfully, was on a tear trough course where they went on the medial border of the bone and then injected the, I think, femoral artery. So if I angle in such a way that if I go too deep, there's no way I'm going to hit anything other than bone, that's exactly what I want to achieve. So I'm going to go, also an unprimed needle, it's pretty superficial. .05 might be my first pass. Now I'm going to change angle, trying not to bruise by going through the same hole and going a little. Okay. Now remembering what I noticed about the slight downturn to her eye, I might attempt to just give a little bit of a lift to the lateral part of her eye, but it's this, you can't see it so well on here, maybe on this side you can see it, there's a little tiny shadow just there, that if I can get that to look slightly more like that, it will give her a more positive aura instantly for a very small amount of product. I can't see it, I think the light is hiding it, but I can see it from where I am, so we'll do a little tiny amount with that. So I'm looking for little superficial veins. I'm going to enter. I'm on the periosteum. Absolutely must touch bone around here. And I'll do a little squirt, 0.05, and then shape that. So first pass, I often use a finger, and then I use the cotton bud. It's just easier to flatten something in a cruder way with your finger, and you get the sensory feedback from using your finger, and then the cotton bud just allows me to roll it in a way that fingers are a little bit less good. So once again, you're looking for those little veins to avoid. This is a bit of a bruisey area. Touching the periosteum. Now some people have a little shape in here, and it can look like you're expecting to hit the orbital rim, and actually you don't. And you can go in and hit the eye. So I'm always very slow as I enter in there, because it's quite rare, but I've had them where you feel, in fact, Lindsay has a tiny hint of one. There's like a little dip in the skull, and I've had a couple of patients where that dip is quite basically pronounced into a V shape. So if you feel above and below, you expect there to be bone, but actually underneath there isn't. So that's very important to know about.
I hope you're enjoying seeing me inject. Don't forget, if you want to be in the heart of the action of this year's Dr. Tim Live event, I've got a whole lot more stuff to show you, and I really hope you'll join me. All you need to do is click on the link down below. In case you're wondering, we will not be putting this year's event on YouTube. Not now, not ever. So make sure you secure your place.
So I'm just going to do a light tear trough treatment just to add a little bit of volume and try and subtract that shadow just a tiny bit. Now, going back to remember the slide of all the complexity and the kind of the way that when you start to look and think that way, there's loads of other things that are still popping into my head, but I'm trying to do the foundations first, and then I might come back and do some tweaking to try and add even more simplicity. As I was saying before, that case of the infraorbital artery being occluded could have been caused simply by an angle of entry that was just slightly more inferior like that. So I'm always trying to enter now at right angles to the facial plane. I'm also aiming medially because most of the vessels are a bit more lateral. And then where I touch the bone, I should be not in an artery, but we check as always with a good long aspiration. Have a good look. And then we do a little bolus. Average bolus here is probably 0.2. You can go to 0.3 in some people quite easily. And a little bit of shape. You can do this with a cannula too. I'm quite happy with the anatomy that it's actually not, it shouldn't really be near the artery with all those things in place. But cannula is acceptable. You will be in the fat though. It's very hard to be as deep without causing quite a lot of pain. Okay, my shaping is just to create that, the pressure is slightly medial. I don't want there to be a bump and then a shadow. I need this to blend in harmoniously. So I'm just looking at this. I'm looking at the overall shape of a cheek, and I don't know if you can see it on the screen, but when you elevate that up, you create more of that catch light that we saw in the cartoon. I don't want this to be have a reflection and then a little shadow and then a reflection. I want that to be projected anteriorly. So I'm going to add a bit with voluma. It's medial to the midpapillary line, so I tend to use a cannula here, because it's safer with the vessels. We've got two ligaments to think about here. You've got the zygomatic retaining ligament and orbicularis oculi retaining ligament. I want to be underneath the orbicularis oculi retaining ligament in the little V shape. And that means I pass through the zygomatic ligament once. Just into the dermis, through the dermis, into the hypodermis. Sorry, needles. So I am going to be close to some vessels here, but a cannula that's right angle to the vessel and that with someone who's being gentle is incredibly unlikely to cause an occlusion or to even get into the vessel in such a way. I have tried on the cadaver course to get into a facial artery with a cannula, and it is possible, but I'm pushing harder than I've ever pushed on a real person. So one of the factors I think that's hard to explain in terms of overall risk are the analog components. Like, we can all debate about needles versus cannulas, but how do you discuss gentle versus rough? It's very hard to even prove what either one of those are. For one of us, gentle might be one thing, and for others it looks quite rough. So, but I think there's something around just being almost treading on eggshells with cannulas that will make you safer. The downside with an occlusion with a cannula is that you have this far bigger injury normally when it does happen. You hardly ever get into a vessel, but when you do, it's far bigger. So there are certain places where I would never put a cannula into a bleeding hole, mainly the nose, because you might be parallel with the vessels. It might actually be the vessel you're going into, but I'm going at right angles to what I think is that's a facial vein that's bleeding. If I feel a bit of resistance, that makes me, and I certainly wouldn't, if I pop through anything that feels significant, then I might stop and aspirate again. Although I don't actually think in places where the cannula is very mobile that it's really likely at all that you'll be in a vessel, but it does work. You can get positive aspirations certainly with the more easily flowing materials, you can get a positive. So it's worth doing if you're unsure. So I'm looking for the tip of this cannula and using that as my guide, feeling with my finger as well. And then I'm constantly in my mind trying to think of this shape I'm trying to create for her cheek. Layering it on, referencing that. And then I do a little bit of molding. The molding afterwards is a really important part of the whole thing. I don't think you can create a perfect shape just with injections, because product tends to flow where it flows. Like if there's a low pressure point in the skin, it just goes there. So now I'm just going to do a little trickle in the tear trough, very low volumes with a cannula. Try and be as deep as I can, but it will be more superficial than with a needle. But I'm not going to put very much in. This is Volbella, which is one I've used for the longest, and a product I feel really happy with in terms of tear trough. Okay, so I'm looking for that little tiny track where I can see the cannula is. I do it nearly all by movement. I can't see it when I'm still. And I'm looking for this mobility as one of the safety aspects. I don't want to see a tip that doesn't move. And I also relying on the on seeing a little bolus as I inject to tell me that I'm not injecting into a vessel. I don't know if you've ever noticed it injecting Botox. Occasionally you'll get into a vein and the product just disappears instantly because you're not in the dermis or the hypodermis. You're in a vessel, so it gets washed away, and that is a sign to stop injecting. I don't like injecting filler if I don't get some visual feedback. So first injection is going to be the temple. And what are we worried about in the temple? It's the first thing you think when I say, would you like a temple injection? I can't hear anyone in particular. Lots of people have thoughts. Someone shout something. Blindness? How do you get blind from a temple injection? Which artery? Temple artery, yeah. So temple artery is superficial. There are two deep ones. Are they also a risk for blindness? It's debatable. I don't think that they are, because they actually come off the zygomatic artery. So you're much more likely to be causing an injury to the branches of the zygomatic, the maxillary artery. That doesn't. So really what I think most of the cases of blindness have come from injecting temples are with low viscosity products injected into the superficial temple artery. And there's a connection. Basically, there's an anastomosis that runs from the superficial temple artery and then connects with the supratrochlear in quite a high number of people. So it's this flow of product all the way down here and then back into the orbit. So what can we do to reduce that risk? It's always a good idea to develop the mental model in your mind of where the arteries are. So anyone who saw me on the trampoline with my kids, there's a video where I just explain that when your heart is pumping, like put your finger on and find out what pulses you can see, because there's nothing better than feeling a pulse to make your brain go, oh, right, there's an artery there. So if you have a nervous patient as well, Lindsay feels quite calm to me at the moment, you can often feel their pulses, and that's helpful. There's a specific thing to avoid. So I can feel the entry of the facial artery here in the notch on the jaw, and that will normally, in most people and everyone, it pulses up in a tortuous fashion towards the oral commissure. It then branches inferiorly to the inferior labial artery and superiorly to the superior labial artery. This will then course in the white part of the lip underneath the muscle, in most cases, but not in all, and starts to pass up as the columellar artery to the tip of the nose. There's always a few cases of these you've got cold sores after a treatment and they diagnose that, but they've actually got a spot on their nose that they've never had before. That's an occlusion, and they're occluded all the way up to the columnar arteries. And a few big cases like that where people understanding the anatomy and diagnosing cold sores are missing a barn door vascular occlusion. If you know your anatomy, you know that an injection here can affect the tip of the nose. So the facial artery then continues up towards the alar of the nose and branches into the infraalar artery and the lateral nasal artery. These are important because if the alar of your nose is painful after an injection, you may have occluded one of those arteries. So this is another thing I've heard people say is, well, I didn't inject your nose, why would it be sore? Well, there is a good reason. They get the blood supply through the same path. Angular artery, which then connects with the supratrochlear artery that comes out of the orbit and supplies the forehead. So you will see people who've had non-surgical nose jobs where there's an occlusion. There's often necrosis that goes all the way up into the forehead when they've been left untreated. The superficial temporal artery then emerges from above the zygoma over here, and we might actually, because I'm going to inject temples, see if we can feel it. So feeling for arteries is a really, as I've already said, a great way of actually turning your anatomical knowledge into reality. And as we said, superficial temporal artery then has anastomoses in most people. And this is where the low viscosity problem, the 2 cases of blindness that I'm aware of from temple injections were both very low viscosity products, which makes sense because they've got to go through these anastomoses. I think if you're using Voluma or something thicker, that's more likely it's just going to get stuck and you'll have a temple occlusion, which, we can all deal with that with a few vials of Hyalase. So the very low viscosity products flow through these vessels much more easily and then can flow into the eye. You've got the supraorbital artery, which also will have anastomoses, but is a smaller vessel normally. And then branching off from underneath the zygoma, you have the the transverse facial artery, and the infraorbital artery that you can often feel a little notch for here. So medial to the mid-pupillary line, throwing vessels downwards. We have the submental artery that flows usually just underneath. It's like in nature, the arteries tend to be hidden where possible. If it's a vulnerable spot, you'll find the artery normally goes to a place where if you were to be injured, it's less likely to be cut. Not always the case, because I have an NHS patient who's got a radial artery on the back of his wrist. It's very scary. It makes you think about these anatomical variations. Okay, so those are the key vessels, and those are the things. Sorry, branching off the most important one actually, which is branching off from the maxillary artery or the deep temple arteries. So these tend to be relatively short if the muscle is small, and they may be bigger if you're injecting them with a stronger muscle, or with a stronger muscle there. That they may, in theory, there's more blood flow. So we want to be careful of these deep temple arteries, which is the last thing that's going through my mind before I inject is what can I do to avoid those. So one of the things that's going to help me later is if I add volume back here, it's going to pull that tissue out. I actually might come back to that. And there's another way of filling the buccal fat pad through here. From where you're doing the jawline, you can go up. So I might do that and give me a bit more of an ability to reach slightly deeper. So realizing that all these tissues affect each other. So chin up here, lateral to the face, cheek, jawline, they're all going to be involved in pulling this structure out. So I'm going to get at it from all angles. She has a little, I don't know if you can see it, there's a little P shape here, which is an indication for treatment along here, and these little lines above her ear, those all tell me that there's fat pad loss, which if I add volume here will pull back. This is a useful indication to see this complexity as well. If you look at the before pictures from 20 years ago, there's none of this complexity. So we can add quite a lot of product here to pull back. So what's directly underneath here? Salivary gland. I'm seeing these injuries come through now, which come from, I believe it comes from getting the cannula underneath the parotid fascia. And it feels different if you're in that plane. It's much harder to pass the cannula, and you're effectively tearing the surface of the gland as you're going. And the patient then gets something that you might think is a hematoma because it comes up quite quickly. But it's not, it's saliva. So there's no color to it and it swells. One of the other clues is that when they're about to eat something, it swells and then it goes away. So it can be pretty disturbing because sometimes they're quite big. And what we need to do is avoid that by being at the right plane. So the first thing I'm thinking about here as I go under is how do I make sure that I'm not too deep? I want to be in the fat. I'm replacing a fat pad, not replacing a salivary gland. And that's sliding nice and easily for me. So that's giving me confidence. And this is a really good way of lifting without making something look done, because you don't really notice this part of the face. It's not one of the signs of being over-treated, but it's a powerful way of lifting. It also increases the height, where the jawline meets. If you can project this bit out, you create that V shape. It's part of what you need to create a V shape, heart shape. I don't want to be anywhere near the nerves here, so I'm also feeling with my finger to make sure that I'm superficial enough. And then a little bit of shaping. Right up here, right at the top, is a place I like to try and chase down. So I'm going to actually try and put a bit more there. I need a longer cannula, actually, if you can put yeah. And it's part of the cheek, and you can do it as part of the cheek, but the facial artery the superficial temporal artery emerges just above it. So I like to do, if I'm going to be this lateral, I like to be with a cannula, and I'm going to add a bit of volume just in that little shadow. And if you can just see there's a tiny little shadow, it's clearer to me than it will be to you, but that's a great place to try and get a lift. It's on top of the bone, so it's quite a long way from where my entry point is. If you turn away from me again. Yes, it is, that's right. So it should be able to reach all the way up. Now my angle of my cannula, once again, is I'm angled in such a way that I won't go unnecessarily deep. If your patient jumps, that could be that you're near a nerve, so also another reason to stop. And then a bit of shaping. I like to the projection and then reconnect it. So what I'll do first is actually it'll look like a downgrade, which is her chin will become more prominent, and then I will connect it afterwards so that it becomes straighter. I might actually do that first and then do some more of the buckle work and then come back to that. I'm trying to assess how much pull I can create. But chins are. I say now she's got, if you look at the before pictures again, she's got a little groove here which she never used to have as well. So this is something, that little separation here, if I can get that to become the new low point on her chin, that will make a really good difference. So that's going to be my first injection, because I know she had a very petite chin with a good angle to it. So I'm completely midline. The other thing is your angle of injection here makes a difference to your aesthetic result. If you're completely anterior, you'll pull it more down. If you're anterior, you'll project it out. I actually want to be, for this first injection, about 45 degrees. Should go in, touch the bone. It's very easy to miss the bone at this point. And then you have to go probably in the mentalis or underneath. Good aspiration. I'm putting a bit of pressure above because I don't actually want to project her chin forward. I want to project it down more than forward. That's 0.2, 0.25. So that's step one. So that's made a nice difference already. Now I may revisit that, but I'm going to do it in stages when I've found out whether I can project this out. So let's do I'm constantly with patients just reassessing how the connectivity of the tissues. And one of the things that's crossing my mind is, can I pull the jowl back more by doing some needle work on the bone to pull from behind, because I really need to get as much as I possibly can. I'm really digging deep to get this to pull back. So I'm going to think about adding a little bit of volume on the posterior ramus of her mandible. Okay, so entry point. I'm thinking about what can I do with this entry point? How can I cover as many places as possible? So I definitely want to cover this connection here, that one there, and that one here. But I'm also thinking about going back into this on both sides, adding some volume from inferiorly. So we'll see how that works. If you can go back on the phone, shoulder, oh, that's it. So this angle does allow me to go a little bit deeper. As far as the buccal fat pad is concerned, but I'm quite far away, so I'm not going to be too near any of the important structures. Oh, I am crossing where the artery might be, so that's making me very respectful of any resistance that I get. A little pop through there, so I'm going to give a good long aspiration. A little bit of pressure so that I get the shape that I want. It's flowing very easily, getting very little resistance. And some of this I'm now going to do slightly more superficially, just in the hope that I get some of the more superficial ripples as well as the deeper volume. And Voluma is a very good product for using in different layers, in my experience.
I hope you enjoyed that insight into the full face and full person approach that I love to teach and practice. Remember, right now there is a super rare opportunity to be part of this year's live audience, to come and meet me and my team and my colleagues, and we've thrown together a cheeky £49 discount only available for 48 hours from the release of this show. Discount code in the description down below. All you need to do is click on the link, fill in your details, and you'll secure your place. Hope to see you there.